Next, we have impact of care fragmentation after major lower extremity amputation, presented by Uri Brandon and the Rush University team.
Good afternoon. My name is Braden Uri. I'm a second-year medical student at the Rush University Medical Center, and I'll be discussing the impact of care fragmentation on major lower extremity amputation. The authors and I have no disclosure to make. Care fragmentation is simply defined as a patient having admissions to multiple hospitals. In medicine, that is associated with increased morbidity, duplicated medications and drug-drug interactions, redundant imaging studies, and more frequent readmissions. In surgery, though, care fragmentation is also prevalent. It was seen to be as common as taking up 25% or a quarter of patients who had experienced major surgeries. That care fragmentation in a quarter of the patients was seen to be associated with 48% increase in mortality after major surgery, as seen in a Medicare inpatient data set, a 75% increase in mortality, and twice as many readmissions after liver transplantations, and a 16% increased number of readmissions after major cancer surgery. Surgeries such as liver transplant and major cancer surgeries are typically performed in regions and hospital centers that are more specialized, necessitating that patients travel further distances for their procedures, which validates some of the fragmentation that occurs in those specialties. However, we studied the impact of care fragmentation on the outcomes of lower extremity amputations because these procedures are more likely to be performed in centers that have already been following the patients. So we collected our data from the Healthcare Cost and Utilization Project, their state inpatient database, using data from the states of Florida, Maryland, and New York, having info from the years of 2016 and 2017 in 2 of those states, and 2016 in New York. Patients were identified as having a diagnosis or an ICD-10 diagnosis code related to atherosclerosis of a lower extremity who had undergone procedures associated with ICD codes related to above, through, and below the knee amputations. Once that group of patients were identified, the exposure group was identified using a series of linking variables that are present in the HCUP database, the first of which being visit link, which is a unique person number that each patient is assigned that allows us to follow them across readmissions and across time. The second being days to event, which is a unique start date that is assigned to each patient that places all of their visits on a timeline, allowing us to compare the time between visits and from surgery. And the third being DS Hosp ID, which is a hospital identification number. Therefore, we can identify patients who have had fragmented care as those visit links that are associated with multiple hospital IDs. We found a total of 2,742 patients that fit those inclusion criteria, with a total of 1,624 having experienced a fragmentation of care, representing almost a 60% proportion of that patient population. In a comparison of baseline characteristics, those who experienced a fragmentation of care had a higher Charlson comorbidity index, but were similar to the control in all other baseline characteristics. In comparison of the characteristics of their first readmissions, those who had experienced a fragmentation of care were more likely to have experienced their first readmission within 30 days. Also within 90 days, they were more likely to experience a longer length of stay on their first postoperative readmission, and also a more expensive hospital charge. The time or average days from discharge of their surgery to their first readmission, however, was similar between those two groups. Averaging all their readmissions, the fragmentation group experienced a greater number of readmissions, a longer length of stay on any given readmission, and a more expensive hospital charge for any given readmission. A regression analysis was run to identify predictors of mortality. The Charlson Comorbidity Index was the only predictor of mortality, whereas the rest of the baseline characteristics, including fragmentation of care, were not predictors of mortality. However, care fragmentation was the only predictor for a 30-day readmission as well as a 90-day readmission. A subgroup analysis was performed on only those who had experienced fragmentation of care, and it was divided into two groups, one being those who experienced their first fragmentation visit on their first post-op readmission, and the other group being all other patients who had experienced their first fragmentation during some other visit other than their first readmission. And it was found that those who experienced their first fragmentation on their first readmission were also more likely to have experienced a 30-day readmission. This is also true for being more likely to have experienced a 90-day readmission. So in conclusion, care fragmentation is an independent predictor of both 30 and 90-day readmissions after major lower extremity amputation, but it is also associated with increased hospital charges, longer lengths of stay, and an increased number of overall readmissions. And so this should motivate us and providers to collaborate and optimize their post-discharge care to minimize the impacts or occurrences of these adverse events. Thank you.
So while we are waiting for someone to come to the mic, so do you have any information on the insurance status on these patients?
Yes, HCUP does provide insurance, and it is a part of their baseline characteristics. We did not find that the primary or the insurance provider had any impact on the results.
CJ?
Do you have any data? Nice job, by the way. That was great.
Thank you.
Do you have any data on the reasons for the readmissions or the diagnosis that landed them after their care fragmentation? Because I think that's very important. And also, do you have any information on the primary outcomes of whatever their situation was in terms of limb salvage or amputation rates or anything like that after their index operation or index care? Because sometimes, my colleague, we practice in Chicago, one of the most fragmented markets out there. So one of my colleagues, maybe out in OBL, gets into trouble. He calls me and says, listen, we have an occluded limb or we have an embolization event that I can't take care of here. So that person automatically comes over. And of course, that stay is going to be longer, but it's necessary. But does that necessarily jeopardize an adverse outcome?
That is a good point. And for the first part of the question, in terms of reasons for readmission, we did not look at that, but there is a tool that HCUP provides that would be good for us to look in, and that could potentially illuminate that there are different reasons for readmission based on being fragmented or not, which would definitely help providers know where to focus their efforts.
Hi, my name is Sung Ho Lim. I'm a Rush surgeon, and I'm the senior author of the paper. So for the region for the readmission, we can identify using the CCI code, but usually those are very categorized into a big group. So maybe we can just put it as a cardiovascular versus pulmonary versus infectious, but it's very difficult to see whether it's a complication from the surgery versus whether it's coded to the complication to the surgery and has an infection in the stump versus someone who has some other problem in the cardiovascular.
Dr. Osborne?
Thanks. Excellent job. Just a couple of questions. One, when you think about the idea of fragmenting care, I think one, you've taken it from the step of they've had the major surgery and looking at kind of fragmented care from that point forward. Have you thought about taking it from the index, like before amputation, but looking at patients who are seen for diabetic wounds or for other things? They've had atherectomy, they've had angioplasties, and going forward with fragmentation from that point before major amputation to kind of see the entire impact, because fragmentation happens at every single step of the way. The other thing that's going to limit you is that you're using an inpatient database, and fragmented care is going to happen on the outpatient side as well. And so we're overall underestimating it. And so thinking about an all-payer database probably to answer that would help you a lot when you kind of think about moving this forward.
Yes.
And the last thing would be just think about the interaction between social determinants of health and the fragmentation of care. I see you put up there you have age, you have comorbidities, you have all those things. Make sure you're controlling for the interactions between fragmentation of care and all those covariates, because I'm sure that there's a lot of interactions between insurance status, age, all these things that we know impact fragmentation of care as well.
That's excellent. Thank you.
Mark, quick question.
Yeah. 2 points. Very nice talk. So when I think of care fragmentation with lower extremity amputation, I think of having a mobility center in your own center so the prosthetist and the vascular surgeon can be on the same page in terms of the care of the patient no matter where they came from. Did you have any way to identify whether or not that kind of tandem care was part of your study, number one? And number two, I'm always interested in large data mining papers and how it relates to your own program and practice. So please tell me what Rush is going to do differently based on your data as opposed to just putting out data at a meeting. Thank you.
Exactly. I think our provider might have something to say about that one. What will he do?
So this paper started from I operated a patient and went to other hospital, and they say, oh, this patient has this problem, and I think they may need to go back to the operating room. And I transferred the patient to our center, and it's actually a nothing. So I think that it's very important to see, vascular surgery, we see our patient and we follow along. And I think that maybe especially with the telemedicine, I think that we can continue to have a good continued care and follow along our patient. That's probably one of the things that I was thinking about it that we can do differently for this patient.
Okay. Thank you.